Good morning, everybody, friends in Poland. Greetings from Belgium. First of all, thank you, Konrad and Jacek, for inviting me to this fantastic webinar. I know how hard it is to keep on organizing educational content in these strange circumstances. But I really must applaud you guys for keeping up the spirit of the Joint Preservation Congress. Of course, I do hope that we will meet pretty soon in real life, maybe in Warsaw or in other meetings we used to visit in the past, because nothing beats, of course, our conversations, discussions, and a beer afterwards. So I'm really hoping that we will be able to meet each other in the pretty near future. For now, I was asked to discuss a little bit the role of the anterolateral ligament in the broader perspective. I will briefly go into the anatomy, but also in the biomechanics and the reconstruction of this anterolateral ligament and what is known until today, and try to provide you with some new insights. These are my disclosures. The anterolateral ligament's anatomy is best studied on a dissectional video. This is one of the first knees we dissected for our publication in 2013, and it shows the oblique course of the ALL in a tripod configuration with the popliteus tendon and the LCL, and also its course inside the anterolateral capsule of the knee. Now, together with other reports, this study generated a heated debate in orthopedic community, giving rise to believers and non-believers of this ALL. Although, of course, you all know that orthopedic surgery is about science and not religion. And luckily nowadays there is a lot of science on the anterolateral ligament available, as you can see in today's PubMed search. Is it really a new ligament, as some people asked? Of course, it isn't. In our publication, we already described that Dr. Paul SEGOND was probably the first to note a pearly resistant fibrous band on the place of the anterolateral ligament while he was describing the SEGOND fracture in this very ancient text, and of which he provided a very nice drawing showing the SEGOND fracture here with the ALL attached to that. So maybe the SEGOND ligament is probably a better name for the ALL, not only because he was the first to describe this, but also because many authors by now have shown that the SEGOND fracture is caused by the pull of the anterolateral ligament at the zone of the anterolateral tibial bone, giving rise to this eponymous SEGOND fracture in some of our ACL injured subjects. The precise anatomy of the ALL, for instance, has been described in this publication, in which we demonstrated that the ALL runs obliquely, originating on the femur on a place posterior and proximal to the lateral epicondyle, and attaching at the tibia in between Gerdy's tubercle and the fibular head. We also demonstrated the connection with the lateral meniscus, of which the clinical relevance to date remains unclear. Long ago, this very nice publication on the anatomy of the anterolateral ligament of the knee was published. It's a systematic review on more than 50 publications discussing the anatomy of the ALL. And interestingly, this publication showed nicely that only 2 of these studies weren't able to find the ALL in the human knee, which means that this could be called overwhelming evidence for the existence of the ALL. Some people have stated that the ALL is just capsule. Well, actually it's not. Not only we, but many others have studied indeed the fact that the ALL is part of the anterolateral capsule of the human knee, but it has distinct biomechanical and histological properties to the capsule, which is more comparable to the IGHL, which is the most important ligament for shoulder instability. Also, the ultrastructure of the ALL has been studied widely, not only in a traditional microscopic study, but also in electron microscopy analysis, which showed that the ALL indeed can be considered a distinct ligament with properties histologically which are similar to typical ligaments like the MCL and totally different than capsule. Of course, biomechanics is probably the most important, and because form follows function, many studies by now have studied the biomechanical role of the ALL. These are just three of the most important studies, which all demonstrated that the ALL has a function in rotational control in the ACL deficient knee, which you may interpret as being the ALL a secondary restraint for internal rotation in the ACL deficient knee. And in other words, the biomechanical studies on the ALL show that the ALL helps the ACL to prevent the knee from pivot shifting. Interestingly, also ALL reconstruction biomechanics have been studied. This is one of the recent studies which compared tendon graft ALL reconstruction on the left to an ITB tenodesis technique to the right, which is actually one operation studied in two different techniques. And I think it's really necessary to stop using these ALL reconstruction versus lateral extratenodesis terminology to avoid further confusion. As you can see on these drawings, these are actually just two operations, two techniques for one same procedure, and both have been demonstrated to be suitable in order to reconstruct the ALL. In the end, of course, only clinical outcomes matter. And this is the reason why these four publications are the very most important publications in the last years, demonstrating the positive effect of either anterolateral ligament reconstruction using a tendon graft or an ITB tenodesis technique in our patients. And all of these four papers, although they seem different title-wise, they demonstrate the effect of an anterolateral ligament reconstruction with either a technique using ITB tenodesis for the upper two or with a gracilis tendon graft for the lower two. And interestingly, all these papers show basically the same reduction in ACL graft failure rates when you combine ACL reconstruction with one of these two ALL reconstruction techniques. And to me, this is the most important finding in literature over the last couple of years. And so I think it's high time to move on, because many of us have been discussing the very academic details on anatomy and biomechanics of the ALL over and over again over the last 8 years. But in order to stop running in circles, I think we should agree to disagree at some of these less important points nowadays. And I think we need to move forward because the subsequent clinical questions raised by these papers I showed in the previous slide, together with other secondary restraints for the ACL, need our attention. And I'm more than convinced that this will be the only way forward. So thank you everybody for listening. I hope we will meet again in the near future, pretty soon in real life. Maybe our soccer teams will meet in the next weeks when we will continue our way up in the European Championship for football. And then I really do hope that the best team may win. So once again, thank you everybody. Thank you specifically to my dear brother Conrad. I hope we will meet in real life pretty soon. But for now, I wish you guys all the best from Belgium. Take care.